Hello, my name is Pradeep Nair. It's a great pleasure to be with you today again for NCVH Digital Education Series. I want to thank Dr. Walker, as always, for inviting us to present at in this series, and also for being a great mentor. We are going to today discuss the utilization of the Occlusion Perfusion Catheter to administer anti-proliferative medications in PAD interventions. Here are my disclosures. So when we look at PAD, we have DCB therapy for femoropopliteal interventions, and it's demonstrated clear superiority over standard PTA with regards to long-term patency. Yet, there's been significant controversy over DCBs in the last 2 years, with signals of increased mortality that is being adjudicated through ongoing research. However, when we look at below-the-knee interventions, we are still trying to find the optimal strategy for treatment. Angioplasty, to this day, is still the most commonly employed strategy, but really yields non-durable results with 63% primary patency at 1 year. And looking at clinical trials of drug-coated balloons and below-the-knee arteries, there have been a wide range of mixed results. And there's still several randomized clinical trials looking at the BTK space with ongoing drug-coated balloon studies, as well as evaluation with vascular scaffolds. For DCBs in particular, Dr. Vermani and her group have looked at potential effects of downstream particulate washout. And what you can see with these drug-coated balloons is that there is embolic crystalline material that can wash downstream and yield either fibrinoid necrosis within the arterioles or skeletal muscle necrosis. Now, with a patient who is in the process of wound healing, this can be a substantial negative effect, potentially create a substantial negative effect for these patients in the process of wound healing. The IMPACT DEEP trial really raised some eyebrows as far as patency in the below-the-knee space. In essence, was a negative trial, but did show an alarming finding of a trend towards potentially more amputations with the use of drug-coated balloons below the knee. An alternative for balloon delivery of paclitaxel and avoiding the excipients is liquid paclitaxel. And the potential benefits of utilizing liquid paclitaxel is its immediate penetration of the drug into the medial layer, its uniform circumferential and longitudinal delivery, its ability to directly deliver the drug to the site at the target lesion, and the ability to perhaps even deliver the drug to uneven and asymmetrical surfaces of the arterial wall. And most importantly, if we can avoid downstream tissue exposure of drug particulates, this may be of particular advantage. Liquid paclitaxel is not new. It has been utilized in PAD studies in the past. The Thunder trial looked at femoropopliteal disease. However, it was a negative trial. This was not localized delivery of paclitaxel to a lesion. It was directly delivered into the vasculature. There was a high dose of liquid paclitaxel utilized, 16.8 milligrams, essentially delivered systemically. The PACAS trial showed some promise for liquid paclitaxel utilizing the combination of ultrasound to assist delivery. This was a single center study of 56 patients, which did show significant reduction in TLR compared to drug-coated balloons. In this study, liquid paclitaxel was utilized at 15 milligrams. It was more locally driven with a distal occlusion balloon. So this brings us to the concept of localized drug delivery of paclitaxel, and in this case, we utilize the Occlusion Perfusion Catheter, which utilizes pressure-driven drug delivery of liquid paclitaxel. The OPC catheter is a FDA 510K cleared device that's 5 French, 14 thousandths inch guide wire compatible. It has an outer diameter of 1.67 millimeters, and there's 3 balloons associated with this catheter. There's 2 compliant occlusion balloons, one proximal and distal, that define the treatment chamber. There's 1 center space occupying balloon that never contacts the vessel wall, but allows to assist in distribution of the drug. And then there's a treatment chamber pressure that is measured real time to monitor the internal pressure chambers for drug delivery. So when we look at this drug delivery, the treatment time is totaling 2 minutes. We infuse the drug, in this case, liquid paclitaxel, under continuous pressure injection. For the clinical trials and study, each dose and each placement of the OPC device delivered approximately 6 milligrams of paclitaxel. And we have radiopaque markers on both sides of the occlusion balloon to define the treatment chamber and know where you're treating. The outer occlusion balloons have a 3 millimeter nominal diameter and can grow up to 4 millimeters. And there's 150 millimeter treatment chamber length for the below the knee device. For the above the knee device, the nominal diameter for the occlusion balloons are 7 millimeters, and they can grow to roughly 8 millimeters if necessary. And the treatment chamber length is 80 millimeters with a nominal working length of 135 centimeters. Here's a schematic of the OPC design. You can see the two outer occlusion balloons, the center space occupying balloon, and the proximal end, you have a fiber optic pressure sensor, as well as an inflow lumen. On the distal end, you have an outflow lumen. And again, this all goes over a 14 thousandths wire. Here's a cross section of the catheter. You see 5 lumens corresponding to each of the device's ports. You have a red port, which is for the occlusion balloons, a black port for the center space occupying balloon, a blue one for the inflow, and yellow for the outflow ports. The beauty of this device is that you can infuse the drug and then you can withdraw any excess drug without any loss. The preclinical studies showed successful delivery of paclitaxel, in this case fluorescent paclitaxel, both uniformly in the medial and adventitial layer in a circumferential and longitudinal manner. And the composition of the drug that's delivered is a combination of liquid paclitaxel combined with iopramide or iohexol contrast and normal saline in a what we call a 1-1-3 concentration. The total paclitaxel concentration is 1.2 milligrams per milliliter. Now, with the excipient addition, what we have found is that drug delivery is enhanced and absorption is enhanced when you add it to contrast. And this has been shown in prior clinical studies. Here's a image of drug delivery using the OPC with paclitaxel in contrast, showing the uptake of the drug on the outer wall of the, in this case, swine model vessel. So, looking at anti-proliferative effects of local paclitaxel and how it affects the restenosis cascade, what we know is that peak smooth muscle proliferation typically occurs within 3 to 7 days after injury. Now, what we want is adequate smooth muscle cell anti-proliferative effects to be sustained beyond 7 days. And this is indeed what's the case with the OPC device with liquid paclitaxel, as you can see in the histology slides on the bottom of the screen. And chamber pressure is an important aspect of this device, as well as drug viscosity, because this really dictates how much drug is absorbed and how much penetration you get. As the viscosity of the drug goes up, as seen in the gray bars, the penetrance actually goes down. As opposed to lower viscosity fluid, there is a improved penetration of the drug. Likewise, when your pressures are increased, you have increased penetrance of the drug as opposed to lower pressures. And why don't we infuse the drug simply with an indiflator? Well, and why do we have a treatment chamber pressure? It's because there's a wide variability between our pressure with an indiflator as opposed to what is actually going on inside a vessel, given its varied compliance. And as you recall, even 1 atmosphere on an indiflator is equivalent to 760 millimeters of mercury. And inside a vessel, that potentially could create some barotrauma if not under strict observation. So the clinical study of the COPPER program, or Occlusion Perfusion Catheter for optimal delivery of paclitaxel for the prevention of endovascular restenosis, looked at both subjects above the knee and below the knee with peripheral artery disease. A total of 112 subjects were studied. In the above the knee cohort, there was a roll-in phase of 17 patients. And finally, there was a phase 2 in which 60 subjects were studied. Initially, the concentration of drug was higher with what we call a 2-2-1 mixture of paclitaxel, contrast, and saline. And what we found is that the higher concentration did cause more irritation and discomfort to the patient. And so we did a protocol change in which we decreased the dose to 113 for the above-the-knee cohort. And in essence, what we found is that the patency was actually better when we lowered the dose. And so we utilized that concentration of drug for the below-the-knee cohort of patients. This is the study leadership and management. Dr. Frank Bunch was the study PI. And this was sponsored by Horizons International Peripheral Group. There were 17 clinical sites in the United States that were enrolling patients. For the above-the-knee cohort, we looked at infrapopliteal lesions that were greater than 20 millimeters in length. The entire cohort was a mixture of Rutherford 2 through 5. All patients in this study did require atherectomy, as the study investigators wanted to keep consistency within the protocol and felt that there may be better drug absorption with atherectomy. To date, in the above-the-knee cohort, at 12 months follow-up, 78.6% of the patients followed up without TLR. And when you look at the 6-month data, 86.7% did not have TLR. And the primary efficacy endpoint for this study was primary patency at 12 months, measured by ultrasound and by a PSVR of less than 2.5, and freedom from target lesion revascularization, as well as the primary safety endpoint of freedom from major adverse events at 1 month. And this included major amputations, TLR, and target limb-related death. Overall, this is a study that encompassed what we see in most clinical trials with patients having diabetes, hypertension, dyslipidemia, and smoking. But this wasn't primarily a trial of claudicants, as the vast majority had Rutherford 2 to 3. And what we can see is that the overall lesion length in the above-the-knee cohort was 131 millimeters. Patients did receive multiple treatments with the OPC given lesion lengths, and the total dose of Paclitaxel for each SFA lesion was approximately 20 milligrams in this study. The freedom from clinically driven TLR, as I mentioned previously, at 6 months was 86.7%, and at 1 year, 78.6%. Safety was established at 1 month with no death, thrombosis, or major amputation of the target limb. And there was improvement in ankle brachial index over the course of the trial. As opposed to the Rutherford scoring of the patients, there was significant improvement in the Rutherford score over the 12-month period of time in which these patients were followed. So overall, when we look at the above-the-knee cohort, we saw some promising findings, and we moved on to the below-the-knee cohort, where we investigated patients with infrapopliteal lesions with greater than 20 millimeters lesion length, again, Rutherford 2 to 5. All patients, once again, received atherectomy. 35 patients were enrolled, looking at 36 lesions. And this was a very promising, we received very promising results from this study with no TLR found at 1 month or 3 months. And at 6 months, TLR was not found in 96.4%. And at 1 year, this was sustained. Primary efficacy endpoint was primary patency at 6 months, as measured by freedom from target lesion occlusion and freedom from clinically driven TLR. And the primary safety endpoint was the same as in our above-the-knee cohort. This study was published in Catheterization and Cardiovascular Interventions recently. We again had a mixture of patients as opposed to the above-the-knee trial. In this study, there was a mixture of claudicants versus a CLI, nearly in a 50-50 ratio. Almost 40% of these lesions were total occlusions. Lesion lengths were 111 millimeters. Most patients did require single treatment, although very high percentage did require 2 treatments. And as I mentioned, all patients received atherectomy, with laser atherectomy being the primary mode of atherectomy in this trial. We mentioned the results, and primary patency was 89.3% noted at 6 months, and freedom from clinically driven TLR was 96.4% at 6 months, which was 92% at 1 year. So to conclude, this was a multi-center study treating below-the-knee disease, which demonstrated the occlusion perfusion catheter's safety and efficacy. And what we see is that the delivery of liquid paclitaxel using this device under controlled pressure was technically achievable without procedural complications. The feasibility and initial efficacy of this device really provides some encouragement, as this may be a new technique with potential advantages for treating below-the-knee intervention specifically. You can imagine that a device such as this could potentially treat long lesions or multiple lesions, all with one device, which may provide an economical option for operators. And another benefit is that we can target our treatment to the site of atherosclerotic disease and not worry about downstream paclitaxel drug loss that you can see with DCBs, and this is particularly important when we have patients with critical limb ischemia. And of course, this was a small study, so we are going to need longer-term follow-up and larger clinical studies to support these initial findings. And in the future, hopefully a head-to-head comparison with DCBs and balloon angioplasty with or without atherectomy will be performed. And I will say that paclitaxel is one agent that can be delivered with a catheter such as the OPC, but there are other agents that can also be studied with this device. And it'll be very interesting to see where the future goes with this technology. And with that, I thank you.